Hello, everyone, and thank you so much for joining us today. My name is Mayur Chandriani, and I'm a senior consultant at Health Management Associates. In partnership with the California Department of Healthcare Services, or DHCS, I'd like to welcome you all to our second webinar in our Assertive Field-Based SUD Services webinar series. I'd like to now hand it over to my colleague, Anika Alonso, who will be introducing herself along with our other colleague, Debbie Witham. Please note that this content was developed in collaboration with our other colleague, Erin Russell, as well.
Good afternoon. My name is Anika Alvanzo. I'm based in the Baltimore, Maryland area. I am an internal medicine trained addiction medicine physician. I have been board certified in addiction medicine since 2010. And I think at this point in my career, I have worked at just about every level of care in the ASAM criteria continuum. I have experience as an OTP medical director, a director of an inpatient addiction consultation service, an outpatient buprenorphine prescriber, and I continue to do a half-day week of addiction medicine at a primary care clinic here in Baltimore. So with that, I'll pass it to my colleague, Debbie.
Thank you so much. My name is Debbie Witham. I am just down from Anika in HMA's Washington, D.C. office. I am a social worker and a lawyer by background. Prior to coming to HMA, I worked for CARF, where I oversaw standards development training and our relationship with SAMHSA for the opioid treatment program accreditation area and the federal policy stuff for all of our accreditation areas. And then prior to that, I was on the provider side, mostly in the Bronx, overseeing a full continuum of behavioral health primary care, which often included a lot of mobile outreach for both HIV and other services. So very excited to be here with you all today.
And we can go to the next slide where I'll cover the agenda. So for today's agenda, we're going to talk about harm reduction and the connection between assertive field-based SUD services, determining the needs of individuals who use drugs, introducing evidence-based harm reduction strategies, and evaluating quality in harm reduction services. And we'll end with time for question and answers. Next slide. And so our learning objectives for today, at the end of today's session, we want you to be able to identify harm reduction gaps in the continuum of care for people at risk of overdose by accurately and systematically determining community needs, describe at least 2 methods for reaching, engaging, and supporting people at risk of overdose, and measure harm reduction effectiveness by naming at least 1 measurable implementation process outcome and 1 measurable population health outcome. Next slide. Okay, so this first section is going to cover the basics of harm reduction and the connection between harm reduction and ASBSSS. We can go to the next slide. So this slide kind of gives you sort of a graphical or pictorial image of the continuum, of drug use. Not everyone who uses substances goes on to develop an addiction. Substance use occurs along a continuum, and the reasons for and the ways in which people use drugs varies, as do the consequences of that drug use. And so whether it be to loosen someone up to feel more comfortable in a social situation, or to numb memories, thoughts, feelings associated with an experience of trauma, the substance for individuals is serving a purpose. And so we really want to challenge this concept that anybody who uses drugs develops an addiction or develops consequences of that substance use. And let me say drugs, we're focusing on drugs, but drugs or alcohol, so substances. And it recognizes the context, the individual and environmental context in which drug use occurs, recognizing that it's not the substance itself that is the sole driver of addiction, that there are multiple factors that contribute to that. Next slide. So when we think about harm reduction, depending upon the context or the situation, harm reduction is often defined in 3 different ways. So first, harm reduction is often conceptualized as a set of strategies that are designed to reduce the potential harms associated with use of substances, most commonly transmission of infectious diseases and overdose or death. And when we think about some of the strategies, some of the most common strategies we think are syringe services programs in which people are given safer use supplies such as sterile needles, or which may decrease the transmission of infectious diseases such as HIV, hepatitis C, or distribution of supplies that may help limit the risk of overdose, whether it's test strips to test for the presence of fentanyl, or distribution of overdose reversal agents such as naloxone. So that's one way we talk about harm reduction. Another way we talk about harm reduction is actually the approach by which these set of strategies are delivered, specifically being non-judgmental provision of services and resources, regardless of the drug use status of the individual being served. And then lastly, in the larger context, harm reduction is a social justice movement that focuses on destigmatization and decriminalization of drug use, with the goal of increasing access to services and care for those who are using substances, including drugs. Next slide. And so the National Harm Reduction Coalition actually developed 8 principles of harm reduction. And you'll see the first 4 here on your screen. So principle number one, it accepts that substance use is a part of our world and works to minimize the harmful effects associated with substance use. Number 2, understand that drug use is a complex, multifaceted phenomenon, which encompasses a continuum of behaviors and acknowledges that some ways of using drugs are clearly safer than others. Principle number 3 really looks at the quality of individual and community life and well-being as the criteria for successful interventions and policies, as opposed to cessation of drug use. And principle number 4 calls for non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live and reside. Next slide. So here you'll see principles 5 through 8. The 5th principle centers those with lived and living experience of drug use, ensuring they have a real voice in the creation of programs and policies that are designed to serve them. The 6th principle affirms individuals who use drugs as the primary agents of reducing the harms of their drug use, empowers them to share information and support each other in the strategies which meet the actual conditions of their use. Number 7 acknowledges that people's vulnerability to and capacity for effectively dealing with drug-related harm is inextricably linked to a number of things, including poverty, classism, racism, social isolation, experiences of trauma, sex-based discrimination, and other social inequities. Again, looking at the larger context in which drug use occurs. And then the final principle is that not attempting to minimize or ignore the real harms and dangers that can be associated with the use of drugs and other substances. Next slide. And so harm reduction has been a philosophy, a strategy for years, for decades now. Long history of outreach and direct engagement, and long history of developing best practices in this approach. So typically, often I think sometimes when people think about harm reduction, they think about the approaches, but they don't realize that this is an evidence-based approach. And we have a lot of data to support harm reduction as a life-saving strategy. So naloxone distribution at community sites significantly reduces opioid overdose. We have now over 30 years of research specifically related to syringe services programs, which have demonstrated that they're safe, effective, and they're cost-saving, particularly when you compare the cost of delivering syringe services programming versus the cost of treating a potentially chronic infectious disease. And then we also know that people who use harm reduction services are significantly more likely to enter addiction treatment and reduce harmful use behaviors. Specifically, people who use SSPs are 5 times more likely to enter drug treatment and almost 3 times more likely to stop using drugs than individuals who don't use the services of a syringe services program. Also have demonstrated increased retention in methadone programs. And this is likely due to the fact that people enter treatment when they're ready, after having engaged for a period of time with a trusted program while they were engaged in active use. And so I think it's just important to reiterate that we have decades of evidence now that this is evidence-based life-saving strategy. Next slide.
All right. So now we're going to talk a little bit more about how this all kind of ties in together with the new requirements under the Behavioral Health Services Act, starting with a quick grounding of what the Behavioral Health Services Act is. So we know that the BHSA expands on what was the Mental Health Services Act. And so now we are including substance use disorders as something that's treated under the BHSA. And then there's specific requirements around reaching the hardest to reach populations, right? Because that's who, to reduce deaths from overdose and from other harms of substance use. And we know that in order to engage the hardest to reach populations, we have to meet them where they are, both literally, we'll talk about that with mobile outreach, but then also where they are in their process, which includes engaging them from a harm reduction perspective. So some of the requirements are counties are required to provide access to all of the FDA approved medications for addiction treatment. And so one of the things that we want to remember here is that we're not just looking at medications for opioid use disorder. This also includes medications for alcohol use disorder and medications for tobacco use disorder. And then also by standing up at least one initiative in each of the following areas. So data-informed targeted outreach on an ongoing basis to BHSA eligible individuals with SUD, engaging them in services, including medications for addiction treatment. And this is a really important part of the new requirements, which is that we're not just saying we're going to build the program where we think we can or where we can get space. We're going to use data to really understand this is where the hardest to reach populations need the services to be held. Mobile field-based programs, so taking our services into the community and to where those hardest to reach populations are, and open access clinics. And so that really means having no appointment times, no wait, treatment on demand. And notice that data is first, because data should really be driving where your mobile field-based programs go, where your open access clinics are located, the hours and times and things that work for the folks that need them. Next slide, please. All right. And so we want to make sure as part of that, that counties are encouraged and promoting a person-centered approach in their assertive field-based programming. And so that includes harm reduction, primary care, post-overdose follow-up engagement services, access to peer support specialists, so those who most need, who with lived experience, who are really able to engage. And then open access clinics. And some of the best practices that we see used by counties are giving people what they need as far as safe use supplies, naloxone, testing strips, bringing primary care to where people are, helping, which means sometimes we're going to engage you with what you need. And that might be wound care or some other thing that the person is interested in. And then collaborating to establish targeted outreach programs, field-based mobile teams. And so that can be part of the county together with partners, or sometimes in smaller counties across counties working together. And so the next slide, and we'll talk about what assertive field-based services are. So that's a proactive, no wrong door approach, right? So there's no wrong way for a person to get into the system. And this is a big change, right? Because we used to really approach services from, you need to show up on our terms. Whereas now we're saying, we're going to try to figure out what you need based on the data and based on what you're telling us. And then making sure that any door that you enter, you're able to access care. And so we want to prioritize to those that are highest risk of overdose. And that includes people who are unhoused, people who are involved in the criminal legal system, and then people with a co-occurring mental illness. And so one of those best practices is harm reduction. And in section 7B62, you can read what the BHSA requirements and guidelines are around harm reduction, but really focusing on that person-centered approach, and then the sharing of supplies that are going to reduce drug-related harm, so that if we can minimize the risk of overdose and the risk of negative consequences.
Okay, so in this section, we're going to be talking about how do you best determine the needs of individuals who are using drugs to help design and deliver your services. And so when we talk about engaging individuals or partnering with individuals and communities in general and people who use drugs specifically, there are some suggested principles for how we go about that engagement. One, it's recognizing that how we define community may not be the same as how individuals who are using drugs define community. And it may be different. They may define community differently than we do. And ultimately, community is determined and defined by those who are in the community. And so when we are looking to engage, we go with their definition. So principle number 2 looks at trusted individuals. So having someone close to the community on the data collection team often opens doors. And access and entry to the community is often improved when you partner with a trusted messenger. So somebody who's known to the community, who's been working in the community. When you partner with a trusted messenger, that increases your entry into the community and potentially acceptance into the community as well when you're looking to engage. Respect is the third principle. So recognizing that community members, regardless of their drug use status, should be treated with respect and dignity, and that you should be looking to create space to understand the identity of the community of interest. Principle 4 is looking at reciprocity and compensation. So community members should be compensated for their time and effort. And they should also have ownership of their data. So often what happens, so I would say in my part of my career, I worked at an academic institution, and you would hear sometimes people would talk about helicopters. So people come into the community, come in, collect data, and then go away. And the community never hears anything else about what happened with their data, the results, the conclusions. And so that is not something you want to do. So you want to partner with them. They should have ownership of their data. And then any findings and conclusions should be communicated back to and confirmed with the community. And then the last of the principles of engagement is power dynamics. So inherently, there are often power dynamics in many of these engagements. And what you can do, as much as we can do to mitigate those power differentials, the better. So communities have long memories. And to build trust, county governments need to consider and acknowledge any historical actions and perceptions, right? Because the way a community was treated in the past is going to impact their current collaborations. And so recognizing that those can come into play and doing what you can to mitigate those when possible. Next slide. So community needs assessment. So programs like AFBSS that are intended to reach individuals who are using drugs and are at high risk of overdose, those individuals need to be included in the design and delivery, right? So to optimize delivery of services for individuals who are using drugs and are at highest risk of overdose, county health departments and the partnering organizations must have a true understanding of the needs of the community. And ultimately, as I said, the community of people at risk should be included in the design of the program. So on the slide, we have some questions that you might consider when you are looking to engage with the community, right? So what drugs are individuals in your community using? How are they using them? What do they need? And I think we need to be intentional about asking the community what they need, because often we have ideas about what the community needs. And you may ask the community, and that they may have totally different ideas. So hearing from the community directly in terms of what they need today. And then recognizing that there's the opportunity to use different members of the team. So most of us at this point are working in kind of multidisciplinary teams, right? And recognizing that every member of the team brings their own unique skill set and experience to delivery of services. And so there are many members of the team who could potentially participate in this data collection, including individuals like community health workers, peer recovery specialists, or trusted community partners who can go out and potentially survey or be used with subsequent recruitment driven by participant referral and then what we call snowball referral. So you engage with individuals and then you have them tell us, who else should we be talking to? and then you go and talk to that person. Who else should we be talking to? And that's often one of the best ways to get data from your community. And I will say that this is typically a shift in how behavioral health services have historically been designed and delivered, where the professionals decide what people need and expect them to show up. So again, I've been working in behavioral health and addiction for a long time. We stand up brick and mortar buildings, and then we expect people who are dealing with all of the potential chaos that occurs with substance use, in addition to all of the other things that they're having to deal with, to just walk in through our doors at the times we say they should walk in. And so this is, again, why this program this is so important, because we are now taking the services to the individuals in the community where they are, bringing them to them and letting them take advantage when it makes most sense for their lives and and what's happening with them. And then again, recognizing that when we are collecting data, we should be compensating people for their time and expertise, right? Next slide. So community advisory or participation. So what are some potential effective strategies for including individuals who use drugs in your committee or advisory boards? One, you want to ensure that your meeting times and dates accommodate the schedules of those that you're trying to engage, and elicit their ideas on how to make the meetings more inclusive. Engage, as we talked about, the importance of having trusted community messengers, community organization, or service provider in recruiting, preparing, and supporting new advisory board members. When possible and appropriate, compensate members for their time and travel. Be flexible with the expected level of participation. You might consider inviting multiple members and allowing for rotating attendance. Using cultural humility and grace where knowledge gaps may exist, and be transparent and respectful. And then it is important that when you are engaging individuals as part of your advisory board, that engagement is done in a meaningful way and not simply a rubber stamp for what leadership's vision or goals are, right? So that it is a meaningful engagement. You are listening to and incorporating their feedback into the design and planning. Next slide. So there are a number of different ways that we can collect data. So there's passive data collection, which often includes review of kind of retrospective or already collected data, whether it's epidemiologic data like incidences of overdose, or health services data in terms of how many individuals were served at a certain event or in a certain program, or program outcome metrics. That data is typically quantitative and often includes, again, either epidemiologic data or surveys. And then there's active data collection. So, and in contrast, active data collection actually entails the processes by which you're gathering new information and data, and ideally getting that information directly from the community. So your surveying often includes open-ended questions that allow for individualized responses. You may consider focus groups that can generate information either at the onset of a line of inquiry, or to complement or verify results that were obtained during a survey. And then also considering individual interviews, which may be more appropriate when you are querying more sensitive topics that may involve self-disclosure. Regardless of whether you're doing passive data collection or active data collection, both forms serve different needs and have limitations and benefits for AFBSS services. Next slide. And this quote came from an article that was focused on effective community engagement. And this article specifically looked at individuals who were injecting drugs. And I'm not going to read the entire quote to you, but I think the last sentence really is of utmost importance. So if recipients are involved in the development process, program services will have more meaning and thus be more sustainable. All right, so this third section is really going to talk about evidence-based harm reduction strategies. We can go to the next slide. Sorry. So this article actually came from the Journal of Addiction Medicine, and was actually an article that was focused on integration of harm reduction into primary care or substance use disorder clinics. But even though this article was focused on more medical settings, I think the approaches listed here are relevant for a variety of different settings. So one, you prevent overdose or certainly reduce the risk of overdose, right? So giving people naloxone, counseling on risk reduction. We talked about providing treatment on demand. So that particularly, again, we're looking at open access clinics, same day intakes, walk-ins, late arrivals, using telemedicine as an opportunity to expand access, um, putting the patient or the individual in the center, right? So an individual or person-centered approach with respect to initiation of medication, not requiring abstinence, recognizing that people will have differing goals. Some may be looking for abstinence, some may be looking for reduction in use. Regardless of what their goals, we should be offering medications. And then we should be using drug testing when it will change our clinical management. If it's not going to change our clinical management, then why are we doing it? Prevent and treat infection. So testing for HIV, for hepatitis, for sexually transmitted infections, and then providing treatment for those when they are identified. Offering vaccinations to reduce risk of acquiring other infections, and then for individuals who are at high risk for transmission of HIV, prescribing pre-exposure prophylaxis or PrEP or post-exposure prophylaxis PEP. Providing harm reduction supplies, distributing condoms, sterile or injection equipment, safer smoking equipment, test strips, and then talking to individuals about how and where they can access this in their community, and then discussing safer injection techniques, safer smoking techniques. I'm in Baltimore. A lot of people in Baltimore don't inject. A lot of people snort. So how to do that safer, right? Not sharing straws. So discussing with individuals how they can be safer, even though they're continuing to use substances. Next slide. So this is just looking at kind of evidence-based naloxone distribution. So again, talked about the fact that in addition to a set of strategies, harm reduction is actually an evidence-based approach. And there have been a number of studies that have looked at what may be the best way to deliver naloxone to essentially saturate a community. So there was one national study that found between 1996 and 2014, over 80% of lay people who participated in the community naloxone distribution were individuals who used drugs. And over 80% of them reported overdose reversals. So again, making sure that the naloxone or overdose reversal agents are getting into the hands of the individuals who are most likely to be present when an overdose occurs. Saturating a community. So understanding where. So we saw somebody said that they're using EMS data. So understanding where in your community overdoses may be more likely to occur, and saturating that area with overdose reversal agents. So again, most people who witness overdoses are other individuals who use drugs. And then harm reduction and SSP services. Again, lot of data, as we said, 30 years of data on this particular approach. And so the best 5 practices that were ranked by the highest panel of experts looked at including naloxone distribution into these services. So making sure naloxone is accessible, that it's needs-based, again, kind of based upon the data, that you have sufficient naloxone supply, that you're offering low threshold, low barrier services, and that people can get it without cost. So next slide. In terms of, we talked about certainly offering supplies to safer equipment or sterile equipment, but also the importance of education and teaching people how to reduce their risk cannot be overlooked. So beyond the distribution of naloxone, there are a multitude of studies that show risk reduction education is effective at changing people's behavior, and that they may not stop using substances, but they may alter the way in which they use substances to decrease their risk of overdose and transmission of infectious diseases. And so it's important to know that we have to consider education a significant part of the strategies of harm reduction. And existing harm reduction programs are ideal settings for this type of education. They're already engaged with the individuals. They already often have trusted relationships, so or in a prime position to provide education, and they're likely already doing that anyway as part of their services. Next slide. Um, so just reiterating that self-determination is a core ethical principle in healthcare, and behavioral healthcare should be no exception. Autonomy has a clear role in developing clinical relationships and trust, and so people are more likely to succeed when they determine their own treatment path and goals, and that when you are engaging with individuals, that you're engaging in shared decision-making conversations, offering choices or menus of options and allowing them to decide which one of those options makes the most sense for them in terms of where they are with their goals and their environment. Healthcare provider actions can support or undermine patient autonomy, clinical attitudes, the language and the terminology that we use, and other behaviors can either contribute to or detract from the environment of shared decision making. And so being very thoughtful in terms of how we are engaging and speaking with individuals that we are trying to serve. And then recognizing that patients' goals can be very varied, ranging from abstinence to reduced or safer use. And rather than imposing abstinence as a goal, we're allowing individuals to be experts in their own lives and validating their individual choice and agency. Next slide. And then I just think it's absolutely, I think we've hit on this before, but we're going to continue to hit on it, that low threshold, low barrier access to medication, particularly medications for opioid use disorder, but not solely medications for opioid use disorder, alcohol use disorder, tobacco use disorder, FDA approved medications for substance use disorder. In addition, specifically looking at MOUD, it's been proven to alleviate symptoms of withdrawal, reduce cravings, decrease substance use, and increase treatment engagement. However, in addition to reduction of substance use and increased treatment retention, medication for opioid use disorder has been associated with a variety of outcomes, about a variety of positive outcomes, including reduction in transmission of both HIV and hepatitis B and C, improved birth outcomes, and most importantly, saving lives. Specifically, people with an opioid use disorder who are treated with either buprenorphine or methadone, which are the two opioid agonist medications, are 2 to 3 times less likely to die from overdose than individuals with OUD who are not treated with one of those two medications. And so making sure that we are providing low barrier, low threshold access to what we know is a life-saving intervention. And then again, and then just in terms of some different models of low barrier delivery of buprenorphine, integrating into SSPs, bridge or open access clinics, street medicine or shelter-based medicine programs, mobile clinics, medication units, all of these low barrier, low threshold approaches have been associated with decreased substance use and also decreased HIV risk behaviors. Next slide. I'm going to pass to Debbie.
Thank you. And so when we're thinking about harm reduction and reaching people where they are, we need to make sure that we're taking into considerations unique populations and their needs. So we're going to start, I'm not going to read to you all the data on this slide because there's a lot, but it's something that's really important to consider is people who are engaging, who are involved in relationships with intimate partner violence. Oftentimes the substance use is used as a force of coercion, another form of power and control. So how do we engage someone who's in that situation? How do we help them stay safe? An example that someone gives sometimes is a person who's in control might be taking their medication from them so that they're having cravings again. Maybe we want to use a long-acting injectable, right? So there's lots of different ways that we think about how do we engage someone and how do we make sure that we're keeping their safety primary. Next slide, please. So a couple of other things to be thinking about is identifying and removing barriers for care. So that could be someone's documentation status and they're not feeling comfortable receiving services, they may not speak the language, and so they may not even be able to respond to your outreach. So how are you using data to figure out the languages that you need to have outreach and engagement in? How do you have things that are accessible for people with disabilities? Reflecting the lived cultural experience and community norms of people who are using drugs and how the intersectionality that's involved. So for people with LGBTQ plus identities, tribal communities, or race. And so we have to think about, for many cultures, what is it like for someone who's using substances, and how might their culture view medications? How might stopping use impact their engagement in a community? Implementing best practices for engaging people who are pregnant and using drugs. That's a very high need population. And then the social complexities that are involved with the people who we work with, and especially in different forms of discrimination, and keeping people's experience in the healthcare and treatment systems in mind when making referrals and how you approach them about services. Next slide, please. And we're going to talk about, as Anika said earlier, this is an evidence-based practice, right? So when you have an evidence-based practice, we have to look at how are we doing with it, and how are we measuring quality and evaluating the efficacy of our work. So we're going to, next slide, please. Start with the different types of measures that we have available to us. And I think the important thing to note is that all of these are important, but we might use some of them at different phases of our interventions and at system building. So structure is the resources that are available. So the inputs, the people, and this is something you're really going to want to be measuring in the beginning. Do we have what we need to set up these programs, right? Do we have the workforce? Do we have a mobile unit? Do we have the data that we need? Process is what is done and how it's done and how much of it is done. So you might be measuring it this at your second phase. How many people are we delivering test strips to? How many people are engaging in our services? Then outcomes is when we really start to look at, is what we did effective? Are we seeing changes in health behavior, changes in the experience of the persons that we're serving, changes in their quality of life, reductions in cost, and are we having a return on our investment? So the next slide, please. A couple of the different benefits are, and some examples of how you might use these structures. So when you're thinking about this, when you're building your programs, a structural measure might be program availability and staffing levels and qualifications. For process, total referrals to other services and proportion that are completed. Number of encounters that include risk reduction education, referrals, or other services. Outcomes, you might look at the population level, so rates of non-fatal or fatal overdoses, and personal level, self-reported improvements in safety, well-being, and quality of life measures. And I think something that's important to remember when we're thinking about outcome measures is you want to look at both, it is important to look at both population and personal, right? Like, how are we doing with the population as a whole? But then how are we doing at that individual level, and is that individual's life being changed as well? And now I am going to hand it back over to Anika for another form of quality improvement.
Yeah, and so these next two slides actually looked at a essentially a quality improvement approach that was done in two naloxone or two syringe services programs over a 6-month period. So they used an approach called the system analysis and improvement approach. And what you can see is that over the course of a 6-month period, syringe services programs engaged in analyzing data to identify gaps, specifically looking at gaps in naloxone delivery. So they looked at gaps in their naloxone delivery cascade. They did flow mapping to identify what are the potential causes of attrition. So when people are leaving and we're not, what's happening, and then brainstorming programmatic changes that they could make to improve or decrease that attrition, and then conducting continuous quality improvement to assess whether those modifications made any improvement, and then doing this cycle over again. So this was a 6-month process, again, in two different SSP programs. Next slide. And so what what the authors did is they subsequently did what they call a time series analysis. So they looked at 52 weeks, so essentially a full year before they implemented this particular continuous quality improvement project, and then the 26 weeks, so half a year, 6 months after initiating. And so the before and after is indicated by the red line. And they specifically looked at difference in the number of naloxone doses distributed on a weekly basis and the number of individuals receiving naloxone. And what you can see that after engaging in this data analysis, modification, and continuous quality improvement project, significant increase, 105% increase in the number of naloxone doses distributed per week, and a 37% increase in individuals who are actually receiving naloxone. So again, recognizing that this is an evidence-based approach and that we need to be taking a continuous quality improvement approach in the delivery of harm reduction services as we do of other services that we deliver. And that is consistent with best practice.
Thank you all so much for joining us today in our second webinar in our webinar series. Please remember we're here to support you. So if you have any questions at all, please feel free to email us here at info@afbsstraining.org. Thank you so much and have a wonderful day.